Hello guys, welcome back to Clinically Clear. Today we'll be covering the next refractory error, that is myopia. Myopia is the most common refractory error. The most common refractory error is myopia. And the trick for myopia is M for M. M for myopia, M for more power, and M for minus lens. You prescribe minus lens. Why do they have myopia? Because they have too much power, they have more power. Definition is just a slight alteration to that of hypermetropia or that of ametropia. That is refractory state of eye in which parallel rays of light coming from infinity are focused in front of the retina with accommodation at rest. It is also known as nearsightedness. So as you can see here in yellow, instead of how it's supposed to be where the blue rays they're coming and hitting the retina, here it gets focused in front of the retina. So now let's look at the etiological classification. First of all, the most common type of myopia, just like how axial hypermetropia is the most common, here axial myopia is the most common. That is, the axial length of the eyeball is too much. So it is more than 24 mm. So because of that, what happens? It gets focused in front of the retina. For every 1 mm increase in axial length, minus 3 diopters of myopia. Similarly, curvatural myopia, too much curvature. That is, a radius of curvature is too less, the focal length is too less, so the power is too high, so it gets focused in front of the retina. Similarly, index myopia. Now index myopia is interesting especially in old age. See, what happens is in nuclear cataract, nuclear sclerosis, the refractive index of the lens increases, and when the refractive index of the lens increases, obviously we know that the power increases, because the refractory index is inversely proportional to the focal length, and 1 by f is inversely proportional to power. So basically, when the refractive index of the lens increases, the power increases, so now it's getting focused in front of the retina. Now the interesting point here is it gives something known as second sight in old age. Now what is this second sight in old age? See, at around 40 years old, almost everyone gets presbyopia because the accommodation gets weaker. They are not able to show near point accommodation, hence they are not able to see nearby objects. But then what happens at age 55, 60, they start getting this nuclear cataract. So because of this nuclear cataract, they develop index myopia. Now the power of the lens increases, so the near point suddenly becomes visible again. So the patient who was struggling to see nearby objects at around 45, 50, at 65 is now able to see the nearby objects again. Feels like as if he or she got another second sight. So this is because of index myopia. There is another type where is positional myopia. Posterior dislocation of lens causes hypermetropia. Now let's say the lens gets displaced anteriorly, then obviously the light rays will get focused in front of the retina, right? So anterior dislocation of lens, for example, wheel Marchesani syndrome. So basically wheel march forward, we always march forward, right? So wheel Marchesani syndrome causes anterior dislocation of the lens, and this anterior dislocation of the lens can lead to positional myopia. And another thing, excessive accommodation. Let's say we give a meiotic drug that causes spasm of ciliary muscle. So when the ciliary muscle is highly contracted, then the lens will also bulge a lot. So excessive accommodation, when the lens bulges a lot, it will lead to curvature and myopia. So excessive accommodation as well. So this is the etiological classification. Now let's go to the clinical classification, which is more important. Now congenital myopia is present since birth. Why? Because one eyeball is way too big. So this leads to that one eyeball where the eyeball is much bigger than the other, it will cause unilateral and very high degree of myopia. So if you leave it untreated, it will lead to refractory type of amblyopia. This way, so you should not leave it untreated. You should correct the refractory error immediately. Now, how do we grade myopia? 0 to minus 3 diopters, low myopia. Minus 3 diopters to minus 6 diopters, moderate myopia. Anything greater than minus 6 diopter is high myopia. So now let's come to the second type, congenital myopia over. Next, coming to the second type, that is developmental myopia or simple myopia, also known as school myopia. This is the most common type. So why is it known as school myopia? In school going children, that is 5 to 15 years old, you will see this condition. Basically what happens, mostly the etiological factors are genetic risk factors. If both the parents have myopia, then the child having myopia, very high risk. If only one of the parents have, then the risk is slightly lesser. If none of the parents have myopia, the risk is even more lesser. So basically genetic factor plays a very strong role. Then there is something known as theory of excessive near work. Basically, during the developmental age, that is 5 to 15 years old, if they're looking excessively at their screen with minimal outdoor activity, then what happens? There is excessive near work. This can also cause biological developmental variations in the axial length or the curvature. Basically, what happens? There are certain variations where the axial length becomes more than normal, the curvature becomes more than normal because of this excessive near work, genetic factors, etc. So these variations are biological developmental variations in what? Axial length and curvature. So what does the child come with? The child who's sitting in the last bench is no longer able to see the school board. So defect in far vision. So because of that, interest in academics might decrease. Or the child continuously squints their eye, half squints their eyes to look at the board and etc. This is because of a phenomenon known as pinhole effect. Basically, what happens? As we know, irrespective of the power of the lens, the more central the ray is, the more it passes undeviated. The more peripheral the ray is, the more, if it hits the peripheral part of the lens, it has to get focused, right? Now in myopia as well, the peripheral rays are the ones that are being focused in front of the retina. The central rays are traveling all the way up to the retina, right? So that is why in pinhole effect, when we squint the eye, the eyelid blocks, not squint exactly, shunt the eye. The eyelid blocks the peripheral rays. So now these peripheral rays that are getting focused in front of the retina are blocked. It's allowing more of these central rays to pass through. So that is why it feels like as if the vision is improving. So half shunting of the eyes. And asthenopia, think about it. The child is sitting in the back bench and continuously shunting their eyes throughout the day to be able to see. So it will cause asthenopic symptoms like headache, watering, fatigue, tired eyes, etc. So these are the symptoms. Next, coming to the signs. So as I told you, there are biological developmental variations in the axial length of the curvature. So the eye appears larger. Now there is something known as proptosis. In proptosis, the eye is so large that it comes even more forward than the anterior orbital margin. That is the anterior superior orbital margin. So here, because the eye is larger, it appears like there is proptosis, but actually it does not cross the anterior margin. Hence, it is pseudoproptosis. Now the eye is large, so obviously the anterior chamber is deep. The cornea is large. The pupils are slightly larger. And also when we do refractometry, school myopia, simple myopia, developmental myopia is only about low to moderate myopia. And also because the eye is still developing, the myopia keeps progressing till the age of 21 at about 0.5 diopters every year. This is not a mandatory thing. For some people it may stop at age 16, age 15, but sometimes it can progress by about 0.5 diopters every year. Fundus appears normal in simple myopia or developmental myopia. This is very, very important because this helps us differentiate it from pathological myopia or degenerative myopia. Now, this is a very rare but serious condition. So, basically, what happens? Why is it known as degenerative myopia? I'll tell you. See, the major risk factor is genetic risk factors when the parents have pathological myopia. And there are other certain minor risk factors which are growth related like nutrition, hormones, etc. So when this happens, there is increased axial growth of the eyeball. The eyeball grows larger and larger beyond even the biological developmental variations. It becomes very large, abnormally large, pathologically large. So this causes what? Whenever the eyeball gets so large, the posterior segment of the eyeball and the retina, etc., they start to get stretched out and they start to degenerate. So that is why pathological myopia is also known as degenerative myopia. Next, coming to the symptoms. So what are the symptoms? Obviously, myopia meaning you will have vision defect. Here, vision defect is not just due to the high myopia, but also if you leave it uncorrected, it will cause amblyopia. And as I said, degenerative myopia. So retinal degeneration can also cause vision defects. Apart from this, floaters. Floaters are what? Patients see certain black opacities in their vision. Why is that so? Because think about it. Here I have a yellow circle, which is what the eye should be normally with the vitreous humor inside. Now what happens? In pathological myopia or degenerative myopia, the axial length of the eyeball is so much so that the eyeball gets stretched. So because of that, the vitreous humor inside is still the same amount. So it starts to get liquefied and it starts to degenerate to form these black opacities known as floaters. So this is one more thing. Then next thing, because the patient has very high refractory power, high myopia, The patient is not able to see anything far, but near things they are able to see, right? Because of that high refractory power. So because of that, they don't even need any near point accommodation. They don't need to converge their eyeballs. They don't need to have any accommodation reflex to see nearby objects. Because of high myopia, their power itself is so high. So, because of this, the patient shows no convergence. So, the eyes are always diverged. This is known as exophoria. So, exophoria can be seen in pathological myopia. Then, as I said, the eyeball is so big that it's even bigger than developmental variations. So, the pupil is also very big. And when the pupil is very big, it allows a lot of light to enter. This causes flashes. This causes photophobia, etc. Understood? Because they are allowing a lot of light to enter, right? So these are the symptoms. Then coming to the signs. Basically, again the same as previous. You have a large eyeball which appears like pseudoproptosis. You have a large cornea. You have large pupils, and here the pupils are said to be sluggishly reactive. Now think about it. When I shine light onto your pupils, your pupils immediately constrict. Why is that so? Because your retina senses the increased amount of light. It sends the afferent signals, and then the pupillary light reflex comes. The efferent signal comes and causes constriction. But as I told you, here the eyeball is so big and there is so much stretching that the retina gets degenerated. So the retinal afferents also get affected, right? The retinal afferents are not taking back the signal immediately. So the pupils also show sluggish reaction, slow reaction. And because the eyeball is large, of course, you'll have a deep anterior chamber. And when you do refractometry and retinoscopy, here you can see a very high myopia, more than 6 diopters. In school myopia or simple or developmental, it is low to moderate, but here it is very, very high myopia. Then coming to the most important, that is fundoscopy. Obviously, the eye is very big, so the optic disc is huge. There is more cupping, but the main problem is, as I told you, in the posterior part, there is stretching. There is stretching and degeneration. So there is disparity in stretching of the choroid, the retina, and the sclera. So because of this, what happens? Think about it. Let's say the innermost layer of the choroid, some breaks start to come. These breaks in the innermost layer of the choroid is known as Bruch's membrane. These breaks in these Bruch's membrane, it exposes the sclera behind the choroid, yellow colored sclera. For example, as you can see here. So this is known as Lacquer's crack. This is one sign. Similarly, because of the stretching, the choroid and the retina, they start to undergo atrophy. This atrophy around the optic disc, you have the optic disc here, right? Around the optic disc will expose once again the yellow sclera underneath. This will manifest as crescent shaped signs. So these are known as myopic crescents. And these myopic crescents are mostly towards the temporal side, not towards the nasal side of the optic disc, towards the temporal side of the optic disc. So these are myopic crescents again. And chorioretinal atrophy, let's say the choroid undergoes degeneration, the retina undergoes degeneration, then what happens? You have only the sclera, right? So the vitreous humor starts pushing on the sclera. So this will cause the weakening and the thinning of the sclera. So this will make the sclera protrude and have an outpouching as seen in this picture. You can see in this picture that the sclera starts having an outpouching. It starts protruding outside. This is known as posterior staphyloma. And a posterior staphyloma is a protrusion of sclera posteriorly which is lined by choroid. These are three things. Even more, there can be lattice and cystoid degeneration. And as you can see here, let's say the retinal pigment epithelium gets degenerated and then the choroid is still intact. Then the choroidal blood vessels get seen because see, before you had the retinal pigment epithelium, you could not see the choroidal blood vessels. Now that the retinal pigment epithelium is being stretched and degenerated, you can now see the choroidal blood vessels. As you can see in this picture, they appear like tiger stripes. So this is known as tigroid appearance or tessellated appearance. So this is one more thing. And also, because of the stretching of the retina, there can be subretinal hemorrhages underneath the hemorrhages near the macula. This is known as Foster Fuchs spot. So as you can see, you have Foster Fuchs spots here. So basically, what are all the signs we studied? First, everything to do with the eyeball size, large eyeball, large cornea, deep anterior chamber, large pupils, sluggishly reactive. Then we did the refractometry. We saw that the myopia is very, very high, more than -6 diopters. Then we did fundoscopy, where everything was to do with the stretching of the choroid, the sclera, and the retina behind. That breaks in the Bruch's membrane led to Lacquer's cracks. Breaks in and Lacquer's crack was what? Those yellow sclera exposed part. Then you had the white temporal myopic crescents because of chorioretinal atrophy. You had posterior outpouching of the sclera because of chororetinal atrophy, which is also known as posterior staphyloma. Then you had subretinal hemorrhages known as Foster Fuchs spots, and you had these tigeroid or tessellated appearance in the fundus because of choroidal blood vessels being seen underneath the retinal pigment epithelium, which is being degenerated. So this is about the signs. Then the complications. Now, obviously, because of the once again because of the stretching of the choroid, the retina, the sclera, there can be certain hemorrhages. There can be a vitreous hemorrhage, hemorrhage into the vitreous humor, choroidal hemorrhage, etc. But the most common complication of pathological myopia is rhegmatogenous retinal detachment. That is basically because of the stretching of the retina starts to break apart and it starts to get detached. This is known as rhegmatogenous retinal detachment. Understood. Then coming to secondary myopia. Secondary myopia, you have secondary myopia is due to acquired changes during lifetime. So basically, during lifetime, there can be certain acquired changes. Example, any lenticonus, cone-shaped lens, keratoconus. That time the lens and the corneal curvature will increase. That will cause curvatural myopia. Consecutive myopia, that is due to human error. For example, I implant overpowered IOLs after cataract surgery, or I overcorrect hypermetropia during LASIK. Then index myopia due to nuclear cataract, positional myopia, anterior dislocation of lens, example, Weil-Marchesani syndrome, accommodative spasm, as I told. These are all secondary myopia changes. Then coming to the treatment. See, the treatment, you have surgery, LASIK, okay, great. But optical treatment, myopia always minus lens, concave lens. But the main problem with concave lens is concave lens can cause minification of the images. It will make everything up look smaller. And also, near vision will be a problem. Let's say there's an object right here, and then the rays will be diverging. Concave lens will make it diverge even more. So, near vision problems might be there. So, that is why we follow a rule, that is minimum acceptance providing maximum vision. What does minimum acceptance providing maximum vision mean? Basically, we always undercorrect the myopia slightly. As long as the patient, we are not going to completely correct the total refractory error. If the patient is able to see, then just how much ever is required for the patient to see, that much will correct. We always undercorrect to prevent minification and to prevent any near vision problems. This is the rule followed when prescribing minus lens for myopia. And also, let's say the patient has unilateral myopia and very, very high myopia. Then why will we give spectacles? We'll always prefer contact lenses. Why? Because instead of having very thick lenses with aberrations, minifications, we'll prefer contact lenses. Let's say a child has myopia. You want to prevent progression. Then you have to make sure they have a lot of outdoor activity, less near work. To prevent any amblyopia, you can give atropine eye drops, and you can give good nutrition to the child like vitamin A and protein. And also, let's say two parents have very, very high myopia. You have to always advise them against having children, because there is a very high risk of the child having extremely high degree of pathological or degenerative myopia that can cause many complications, as I have mentioned above. So genetic counseling to parents if both of them are myopic is extremely crucial. So that is how we prevent progression. So that is it for myopia. I hope you guys enjoyed the video. Thank you for watching as always.